From a radiation standpoint, the biggest thing we're looking at is the treatment site, the dosage, and the way the radiation has been delivered. There are different ways that we can focus radiation using methods such as intensity-modulated radiotherapy, volumetric modulated arc therapy, flattening radiation beams, and proton beam therapy to try to help minimize radiation exposure to healthy tissues to minimize patient risk for secondary cancers.
You're listening to the ONS podcast, where ONS Voices Talk Cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between. Hello and welcome to the ONS podcast. I'm your host, Jaime Weimer, Manager of Oncology Nursing Practice at ONS. And today we're talking with Andrea Matsumoto, Radiation Oncology Nurse Practitioner at Henry Ford Health in Detroit, Michigan, about radiation-associated secondary cancers. As a reminder, you can earn free NCPD contact hours after listening to this episode and completing the evaluation that we've linked to in the episode notes. Welcome. Thanks so much for joining us today, Andrea.
Thanks so much for having me. I'm happy to be here.
So we all know radiation therapy is a cornerstone, one of the pillars of cancer treatment, known for its effectiveness in targeting and destroying cancer cells. However, it's important to recognize that radiation can sometimes lead to the development of secondary cancers. Now, radiation is not alone. We know that there are many systemic therapies and chemotherapies that can also carry this risk. So we're not picking on radiation today, just focusing on it. So to start our discussion, can you explain what those mechanisms are behind these radiation-associated secondary cancers and why they happen? Why do they occur?
To really understand what leads to the secondary cancers, it's important to understand how radiation works in general when we're using it to treat cancer. Radiation is an ionized particle or power, basically, that's used to cause radiolysis or molecular damage. It can cause reactive oxygen species or free radicals, which are unstable atoms that are formed during metabolism or by environmental toxins. The radiolysis or molecular damage caused by radiation and then the damage that these reactive oxygen species can cause impacts DNA and proteins in cells. By damaging the DNA or the proteins that are created is how we damage cancer cells. However, it's hypothesized that radiation can also induce different DNA mutations in healthy cells or in tissues surrounding cancers that we're treating, including alterations in the structure of signal genes or chromosomes, or also causing changes in gene expression, which may help develop a neoplasia or a cancer in a patient's future. The development of cancer carcinogenesis that is impacted or caused by radiation has to do with the chemicals that are produced, the impact it has on cell proliferation, and how these changes and mutations can also pass on to daughter cells in the future as cells are replicating.
That's very interesting. And I appreciate you starting kind of from the beginning, because you're right. We can't understand why this happens unless we first understand how radiation therapy works. So I appreciate you giving us that background information. Let's talk a little bit about the risk to patients that are receiving radiation treatment. In general, what is the overall incidence of radiation-associated secondary cancers?
Well, I've got to tell you, that's a really hot topic in radiation now. People are still publishing studies trying to determine and evaluate the overall incidence. It's been very historically difficult to track and document because, as you mentioned at the beginning, therapies such as chemotherapy can also contribute to the development of secondary cancers. So it can be hard to distinguish the true cause of its development. And we know that with radiation, the risk for developing a secondary cancer is higher in young patients than it is in older patients. So when we're reviewing research articles and publications about secondary malignancies related to radiation, every article and everything I've reviewed, it really varies. Many articles and publications that are evaluating the prevalence and incidence of secondary malignancies are also kind of all over the board in what they're reporting. On average, we know that the risk is oftentimes less than 5% for patients, but there have been analyses, specifically there was SEER analysis conducted between 1973 and 2002. And we all always consider how recent a publication was to how pertinent it is to the information we're providing patients. But that publication showed that there is about an 8% prevalence of secondary cancers related to radiation. I think since then, there have been a lot of treatment changes and improvements in the way we're delivering radiation. So that's why many of us believe that risk is much lower at this time. but we still cannot give most patients an exact percentage of what their risk is when we're talking about their future and chances of developing a secondary cancer.
As part of that discussion with patients or of what you found in the literature, are there any sort of identifiable patient factors or characteristics of the cancer itself that are associated with or more likely to result in a secondary cancer?
One of the biggest ones we always tell people about is the younger age. Younger people are much more susceptible to having a secondary cancer, especially because we know with treatments, we expect them to live a longer time. And once patients get to 5 and 10 years out from radiation is when we may see a secondary cancer develop. We also have seen research showing that females may be more sensitive to some of the carcinogenic effects of radiation. Underlying diseases and genetic mutations can also impact patients' risks. And also, over time, exposures to different potential carcinogens, such as cigarette smoking and alcohol usage as a cancer survivor, may also impact these things.
Yeah, that's a really important point that you've just brought up, is that radiation is just one player in other things that create and bring risk to people developing cancers. And certainly radiation might be a strong and important factor, but it's in combination with all the other potential carcinogens and risk behaviors, things like that, that can influence that development of cancer. So I can understand why it's probably challenging to kind of tease it apart. It was like, what caused this? Or is this really the radiation? Is this somewhat the radiation, but also other factors? And so I can see how that must be very challenging to really point a finger and say, well, this was a result of the radiation. Now, we know the radiation is not always given alone, certainly can be, but certain treatments are used in combination with radiation. So is there any different in terms of the risk factor or the prevalence of secondary cancers developing based on kind of what radiation is given in combination with?
The biggest culprit we look at in combination is, of course, the use of chemotherapy. Chemotherapies such as alkylating agents, platinum drugs, and anthracycline topoisomerase 2 inhibitors have been known to have a higher risk of patients developing a second cancer. And these agents are used frequently, especially in pediatric cancers. For example, ifosfamide, which is an alkylating agent, and doxorubicin are used in the treatment of different sarcomas. Etoposide, which is an anthracycline, is used when treating lymphomas. And there are many alkylating agents that are used during a stem cell transplant, which can also increase a patient's risk for developing a secondary cancer. And those diseases that I've just discussed are also frequently treated with radiation therapy.
Now, so you alluded to this earlier, but what are some of the strategies that we as healthcare professionals and those practitioners in radiation, what are the strategies that we're using now to help reduce or minimize this risk of secondary cancers following radiation therapy?
From a radiation standpoint, the biggest thing we're looking at is the treatment site, the dosage, and the way the radiation has been delivered. There are different ways that we can focus radiation using methods such as intensity-modulated radiotherapy or IMRT, volumetric modulated arc therapy, VMAT, using something called flattening radiation beams and proton beam therapy to try to help minimize radiation exposure to healthy tissues and tissues around the treatment site to minimize patient risk for secondary cancers. We're also looking at radiation dosages and evaluating what the highest dose a patient really needs is, because we know the risk for developing a secondary cancer goes up with the higher doses of radiation. There's also been research looking at factors that can increase individual risks of radiation-induced secondary cancers, such as different germline mutations, such as in the TP53, RB1, and MUTYH genes. Being aware of this as we're expanding the use of genetic testing in all of our patients and being aware of mutations they may have, even if it may not necessarily say, oh, they're going to be at a higher risk for developing a cancer, but if it is associated with a potential higher risk for radiation-induced cancer in the future, those are important details to include in notes and in communications with providers as patients move into survivorship.
And again, you've just reinforced how it's complex. It's not just one single factor that is necessarily driving the risk. Certainly it's a combination of environmental factors, genetic factors, as you mentioned, therapy-related factors. And so it can be challenging to give each individual patient, what is your unique risk? What does it mean to you? But as you said, sharing all the information that we have, being aware of all the new important factors that are coming to light that we need to keep in mind, it makes it important just to share those details with patients so that they can go into that decision with all the information in hand that we can offer them, so that they can make that treatment decision as informed as possible. So let's talk a little bit about just how we educate our patients. What are some of the important points that you think nurses should teach patients about these risks associated with radiation and how they should manage living with those risks?
As my team always says, our nurses are kind of our front line. Whenever patients undergo a radiation planning scan, they're going to meet with our nurses to talk about acute and long-term side effects. This is key during radiation and also as they come in for follow-up and as they finish treatment to make sure that patients are aware of any possible changes, not only some of the radiation specific changes like fibrosis or skin changes, but also the fact that if they see changes in the treatment field, if they feel a new mass, if they notice something that they're just not sure about, that it's important to bring up to their team. And we know patients might be a little more forthcoming with the nurses that they're meeting with before the providers. And so to ensure that nurses are up to date with these risk factors as well and aware of where a patient was treated and what we would be looking out for is really important. Another thing to point out is that patient-specific screening is really dependent on where they were treated. So, for example, if a patient received head and neck radiation, we're monitoring the thyroid, not only for hypothyroidism, but for the potential development of a malignancy of the thyroid, especially if they were younger during treatment. Or somebody that received lymphoma or any chest radiation may need to begin mammogram screening for breast cancer sooner than the general public.
As I was thinking, as I was listening, our patients already carry with them a legitimate and really impactful fear of recurrence. I think most patients, regardless of what therapy they get and the success of it, I think that's something that many patients struggle with, is that fear of recurrence. And so then when you layer on the fear of a new cancer developing because of the treatment you got for the first one, that can be a challenging conversation to have with patients. And so, as you mentioned, nurses being that trusted frontline access and support for patients, of just encouraging them to be forthcoming, report what concerns they have. And more often than not, we can thankfully reassure them that, this is not related or nothing to be concerned about, or we'll just continue to monitor. But, the sooner that they do bring up concerning symptoms that we as nurses know probably doesn't track with what you've gone through or what we know your treatment included, the sooner that we can identify it and hopefully put them on the path to the treatment that they need. But it is a challenging conversation to have with patients, of asking them to treat your cancer now, but also maybe get cancer later. So it's a difficult needle to thread, but I know nurses and physicians who counsel patients do a great job of that, because I think patients rely and trust on what their healthcare providers are telling them.
Exactly. And I can say we do, especially with our older patients, we can tell patients that the risk of developing a second cancer is quite low. And so oftentimes treating the cancer that is there, the benefit of doing that and making sure our patients are able to achieve a long cancer survivorship with that low risk, we remind them, your team is always here. We're always going to be here. And if something comes up, we'll help you manage and guide that. But it is a really big player in the mental aspects of being a cancer survivor, like you said.
And you mentioned earlier, kind of related to this, we know cancers are being diagnosed at a younger age. We're unfortunately seeing that trend. And so how does that impact sort of that benefit risk discussion and analysis for those patients who we think are going to have and hope to have a very long life expectancy?
The big thing is really figuring out the best treatment recommendations. And treatment recommendations are different for all diagnoses and all patient ages. And sometimes if we can use a systemic therapy to help adequately get good tumor control, we may be able to either omit radiation or shrink the field of radiation, which is going to help long-term in reducing risks that are caused by our specific treatment. We really know, and this is kind of where we start to get into biases, where of course we want to help treat the cancer that's existing and with everything we got and leave no areas unchecked to make sure we threw the kitchen sink at it. But we also are, with all the advances we have in all cancer treatments, we need to become more aware of what survivorship and long-term life is going to look like and make sure all patients have that information, and parents of children who are going through treatments, so they're able to really consider the risks and be aware of what they may need to look out for and speak with their children as they grow up as well.
Now, you touched on this just briefly, but I do want to come back to it, of just as these patients do move into sort of long-term survivorship, what are some of the long-term monitoring or follow-up care that we should be providing to our patients, counseling them if they have received radiation therapy? What should we be watching for and telling them to watch for to help detect and hopefully identify any of these secondary cancers as early as possible?
Excellent question. And, it really does depend on what cancer was treated and what area received radiation. Sometimes it can begin with a change in labs if we're looking at the thyroid. Sometimes it may be a new mass somewhere, such as in the breast, or a skin change. Angiosarcomas can be caused by radiation, and sometimes people will just see a change in their appearance of the skin, or something that they're not quite sure if it's related to a mole or a bruise. There's a lot of extra nursing considerations that are required to help evaluate patients physically and also psychologically to manage and promote their quality of life through this continuum of their care and navigating their screening. Another really important thing is that when we're talking about high-risk screening for people, especially children and AYAs who have been treated for cancer, is that high-risk screening, such as getting a mammogram before the national recommendations, may require extra time from nursing and nurse practitioners to obtain prior authorizations or perform peer-to-peers to really help care teams from not only the people in the clinic, but also administration and insurance companies to ensure that they understand why certain testing it may be needed for these patients that would not otherwise be recommended for the general public.
Absolutely. And, what strikes me is that this is a shared oversight for all oncology nurses. My experience has been that we're seeing, they're saying a patient is seeing both medical oncology and radiation oncology. At the conclusion of therapy, they continue to follow with both sort of subspecialties for a time, but at some point, especially for the patient's convenience, sometimes we do condense those and they follow exclusively with the medical oncologist. And so that's going to be important for all nurses to know, even if you don't work specifically in radiation, to be aware of what these risks are so that, if you are that patient's primary source of kind of survivorship follow-up and touch point, that we're being mindful of these side effects that are related to therapies that maybe we weren't involved in providing to the patient, but now it's our responsibility to keep monitoring them. So I really appreciate, Andrea, I appreciate your time today and all the great information that you've shared so that we can all learn and do better for our patients. As we reach the end of our episode, we like to always finalize things with a series of quick fire questions just to help summarize some of the questions or topics that we've discussed today. So to start that off, how do you think healthcare professionals should evaluate their hidden or maybe their implicit bias that they bring when caring for patients and the sort of the risk of radiation-associated secondary cancers?
I think a big thing is remembering that although the risk is really small, the risk does exist. And so it's something that we want to bring up with patients. And even if it is something 20 years down the line for a child being treated, making sure that this information is written down somewhere. So when reviewing records, anyone from a care provider to a family member may be able to say, okay, I see that, and I'm going to keep that on my radar. And that's another big benefit of using NP and nurse-led survivorship clinics and creating survivorship care plans. Another big thing is that patients may struggle to get to all of their follow-up appointments, and depending on their financial resources or maybe their work and school schedules. And so remembering that even if patients aren't following up perfectly the way we all wish in an ideal world, ensuring that when we are seeing them, we're always having these discussions about the long-term side effects from everything we're watching out for as a way to keep re-educating them each time we see them. And also, as we look, sometimes different sites are transferring patients back to their primary care teams after a certain amount of time from their cancer treatments. And so trying to remind or document that the national cancer screening recommendations may not apply to these patients the way they do for normal adults once they get to their 40s or 50s. So certain patients are going to need a little bit of extra time and review. And again, that we all don't love interacting and going back and forth with insurance companies, but these are patients that are going to need a little bit of that extra time to make sure we're giving them the best care throughout their life.
What do you think are some common misconceptions about radiation-associated secondary cancers?
I think from a patient and provider stance that they are and they are not guaranteed. A lot of people go, oh, it's not going to happen. Let's keep going. And then a lot of patients go, well, I'm definitely going to get this. And so trying to educate people about this middle ground and the risks and the surveillance are really the big thing. And then, was this really related to chemo or was this really related to radiation? Sometimes we want to look at the other therapies and hope that it wasn't therapy that our teams provided.
What's something about this topic that's not often discussed, but you wish people knew more about?
Truly just how difficult it is to predict. There are so many causes that can contribute to a potential secondary cancer. And there is also so much unknown that we don't know that it's not of a clear discussion or clear risk that we have a lot of research on. And so it's something that could definitely use more time from all of us and more evaluation in different clinics and labs.
What additional training or education do oncology nurses need to stay current on this topic?
I think it's really helpful for oncology nurses to understand the treatment recommendations and the plan from the radiation oncologist. And even if we're not the ones doing the treatment planning, kind of understanding why different radiation delivery modes, such as the volumetric modulated arc therapy, that VMAT, why this is being used as opposed to a different type of cancer. And then also trying to stay up to date on the research, following different articles, such as in the Clinical Journal for Oncology Nursing that we all get, looking for different research that may be coming out about mutations and new patient risk factors.
And then finally, what are some additional resources that you might recommend for patients or other providers who want to learn more?
So the American Cancer Society, National Comprehensive Cancer Network, and National Coalition for Cancer Survivors all have a lot of wonderful documentation about survivorship, continued screening, and different risk factors. For example, in the NCCN patient guidelines for survivorship care, they have a whole chapter based on potential second cancers related to treatments. And they even have a table that shows what radiation therapy to this site may increase your risk for this. So patients are aware, and it's a really wonderful guideline for patients to look at and reference. There also was a bill introduced in Congress initially in 2023. It's called the HR 4363 Comprehensive Cancer Survivorship Act. I've recently learned about this in December 2024. It was referred to the Subcommittee on Health, and it's really looking at helping further support cancer survivors financially and medically, making sure they're getting the best care moving forward. And I'm hopeful that bill will make it farther through Congress and hopefully get passed so we can find more ways to better take care of our patients and ensure they're getting all of the right screening for secondary cancers in the future.
Andrea, thank you again for spending your time with us this afternoon and talking with us about this really important topic. I really appreciate your time. Do you have any final comments to share with our listeners?
Thank you so much for having me. This was a really interesting topic and required a little bit of extra relearning for me. So it was hopefully beneficial to give you some more information and also know that it's always kind of a developing area that we're trying to evaluate more so we can improve our patients' care.
Outstanding. Well, thank you so much.
Take care.
Thank you for listening to the ONS podcast. Tell us about your favorite part in this episode by leaving a review wherever you download your podcast. For more resources and information about oncology nursing, visit us at ons.org and ons.org/voice. The ideas and opinions shared in this episode represent those of the guest and not necessarily ONS.